consultants. Good evening to all my senior.
Okay, so with all your permission, I'm starting with the Clinic video. Yeah, a very good evening and a warm welcome to one and all present here in this session. I am Tebulina from Clinic. We are very much proud to be a part of this webinar as a digital partner. So now with all of you, I am going to share a short glimpse of Clinic. Thank you so much all for your patience. You all are invited to visit our website, which is www.clearnet.com. So now, without further delay, I'd like to hand over the session to Dr. Shweta Trivedi ma'am to start with the scientific program. Over to you, ma'am.
Thank you so much, Deborina. Yes, good evening to all my senior consultants and all my colleagues. Hello. Hello. Yes, am I audible?
Yes, there was some disturbances in between.
Sorry,
She went into mute in between.
Yes. So good evening to all my senior consultants and all my colleagues. Rajkot Menopause Society. Welcome.
You've gone into mute again, I think.
Problem must be internet problem.
Hello.
Hello.
Internet problem. It is not seen at all now on the screen.
Problem is with internet problem.
Should we wait for her or will Hina Popat take over?
Hina, you can take over.
Yes.
Good evening, everyone. Welcome, Savita ma'am.
She's come back.
Hello.
Yes, Shweta, go ahead.
Okay. Please, sorry. थोड़ा कहीं ऐसे network no problem होता. I'm so sorry.
It's all right.
Okay, okay.
So we should start the webinar with a prayer. That's what I believe. So let us have a small prayer before starting the session. Guru Brahma, Guru Vishnu, Guru Devo Maheshwara, Guru Sakshat Parabrahma, Tasmai Shri Guru Dev Nama. Yes, welcome all. Rajkot Menopause Society presents Indian Menopause Society presentation webinar series on our topic osteoporosis. I would like to invite now Dr. Ami Mehta ma'am. Ami Mehta ma'am is a senior consultant and gynecologist. Madam is the president of Rajkot Menopause Society. Ma'am, I would like to hand over the stage to you for the welcome note of the series. Thank you, ma'am.
A very warm welcome to all on behalf of Indian Menopause Society and Rajkot Menopause Society. I heartily welcome President, respected Dr. Shobna ma'am, Dr. Anju Soni ma'am, and Dr. Atul Munshi sir. Our today's speaker, Dr. Jyoti Ben Shah, she is backbone of our Rajkot Menopause Society, and chairpersons Anita Shah and Varsha Dhruv. Today's our esteemed panelists are Dr. Ketan Bhai, Dr. Devangi Ben, Dr. Beena, Shaili, and Hina. Again, I welcome you on behalf of both association. And now, Shweta, you do further proceedings. Thank you.
Thank you, ma'am. Thank you so much. I would like to introduce our today's guest of honor, Dr. Atul Munshi sir. Atul Munshi sir has been the past president of IMS. Sir presently is the director at the Munshi Group of Hospital, Ahmedabad. Sir was also the past president of Ahmedabad Obstetrics and Gynec Society. And sir was a former professor and HOD of GCS and NHL Medical.
That is sufficient. People know him. That's all. Thank you. Thank you.
Sir, I would like to ask you to say a few words to give your wishes and blessings, sir.
Good evening, everybody. Thank you, Shweta, for kind words.
Thank you,
At
sir.
the outset, I congratulate Rajkot Menopause Society for choosing such an important topic for today's webinar. A much discussed but still fully unexplored subject of osteoporosis. Relatively a silent but often debilitating disease. We are all aware about the consequences of a fracture in an old lady. We must have seen many in our own family also. The good part is many of these causative factors are preventable or modifiable. And today I wish that we might be discussing all the things about osteoporosis, but we should like that how to prevent this. Prevention is always better than any type of treatment. Today we have expert speaker like Dr. Jyoti Shah, panel moderator Dr. Shobna herself, with learned panelists from Rajkot. I'm sure at the end of the session, you all will go lots of additional knowledge in the subject of osteoporosis. I take this opportunity to thank Dr. Ami, Dr. Hina, and other office bearers of Rajkot Menopause Society for inviting me for this interesting topic. Next time I'll see that I'll be one of the speakers rather than only a guest. Dr. Shobna, Dr. Anju, and Dr. Anita, and other office bearers of the Indian Menopause Society are doing excellent work in the field of menopause. I continue them in a same better fashion. Shobna is also inviting us in some other things. Thank you very much, and all the best for an excellent webinar.
Thank you, sir. Thank you so much. I would also like to invite our second guest of honor, Dr. Anju Soni ma'am. Dr. Anju Soni ma'am is the Secretary General of IMS of this year 2022-23. Ma'am have been also the chairperson of HIV and AIDS Committee of 2022 and 23. Ma'am is the president of Jaipur Menopause Society in 2017 and 19. Ma'am has been the HOD of Obstetrics and Gynec Department at Sony Hospital, Jaipur. Ma'am, I would like to ask you to say a few words on
Thank you so much for your kind words. Let's not waste time
Yes,
and decrease the time of academics.
Yes.
When it comes to osteoporosis, I think we all think that we know a lot, but we hardly know anything. It's a very, very complex problem, and in our life, we don't even know how and when our bones become like a butter in our body, and they are melting inside, and they're becoming like so fragile, and because there are no symptoms, so it's not easy to diagnose the osteopenia and osteoporosis, and that is where the problem lies. So it has been seen that osteoporosis is a bigger killer than the cardiac disease. The burden of osteoporosis is much higher versus cardiac disease, which has been projected all the time that after menopause the women are suffering from cardiac problems and this and that, and there is a lot of mortality and morbidity. But I am telling you that when you go to the literature, you will find out that the mortality and morbidity because of osteoporosis and osteopenia and osteoporosis is much higher, and with the increasing age in the population all over the world, this is gonna go higher and higher, and we are going to see that a lot of women will suffer from this problem. And all of us know that the most common fractures are fracture of vertebra, colles, and femur neck. And if a person suffers from a fracture of femur neck, in most of the cases there is a morbidity within a year's time. So severe is the problem. Then I congratulate Shobna Mohandas, Dr. Shobna Mohandas, our president, who has chosen this topic and focus on this topic. And today's, when you look at this program, you will be see that how she has covered each and everything in such a short time, and we will get the gist of whole of the thing in little time, which we are getting, and we will gain so much from. We have got very good panelists with us, and a very dashing and dynamic president, Dr. Ami. She chose to take the webinar. When I was talking to all of these presidents, she was the first few who said, no, I want to do in my place, madam, we give me a date. And that is how it started. And with a beautiful and dashing secretary, who can avoid to mention her name. We cannot think of avoiding your name. And of course, the incoming president is also very energetic. And Dr. Dr. Varsha is also very enthusiastic. So I'm sure in Indian Menopause Society, the way we are growing with academics and other things, we are going to rock as usual. So my best wishes and congratulations to Rajkot Menopause Society. And I hope this webinar today will definitely benefit lots and lots of people. And just now only last year only I had a fracture of my wrist, and I know how it is. Of course, it was not a fracture because of a trivial accident, but it was a fracture and I had to bear with it. So I have seen it, I have felt it. So I am stressing on this need of screening so that none of the women suffer from this problem. Thank you very much and my best wishes.
Thank you, Anju ma'am. Thank you for your kind words and blessings. Let's move forward with our first topic of the series today. So our topic is risk assessment in osteoporosis. I would like to invite our chairpersons for the topic today, Dr. Anita Shah ma'am and Dr. Varsha Dhruv ma'am. Dr. Anita Shah ma'am is a past press secretary of IMS. Ma'am is also president of Surat Medical Consultant Association 2022-23. Ma'am is a vice president elected for the Indian Menopause Society for the year 2024. We wish you all the best, ma'am. I would also like to invite our second chairperson for this session, Dr. Varsha Dhruv ma'am. Varsha Dhruv ma'am is a senior consultant of obstetrics and gynec at Rajkot. Ma'am is an elected president of ROGS, that is Rajkot Obstetrics and Gynec Society. I would like to hand over to Dr. Varsha Dhruv ma'am to introduce our speaker, Dr. Jyoti Shah ma'am. Ma'am, over to you.
Thank you, Sweta.
Yes, thank you.
Our Dr. Jyoti Ben is a senior gynecologist practicing since more than 47 years. At present, she is practicing as Rajkot, and she is past president of Rajkot Menopause Society, past president of Rajkot OBGYN Society. Over to Jyoti Ben.
Jyoti ma'am, yes. Ma'am, you have to unmute yourself.
Good evening, friends. And at the outset, I would like to thank our IMS President, Dr. Shobana, Dr. Anju Soni, and Rajkot Menopause Society President, Dr. Ami, Dr. Hina, for inviting me for this talk. Today, I will be talking on risk assessment in osteoporosis. This is very important topic because, you know, osteoporosis, as we all know, is a silent disease, and when fracture occurs, then only we come to know about it. And it's a global world. WHO has declared it as a global disease, and currently more than 200 million people are suffering from osteoporosis world over. And as per IOF worldwide, 1 in 3 women and 1 in 5 men over the age of 50 years are suffering from this silent epidemic. It is estimated that globally there is 1 osteoporotic fracture that occurs every 3 seconds. This shows the gravity of the problem. In India, around 50 million people are estimated to be either osteoporotic with less than T-score 2.5 or have low bone mass with T-score ranging between -1 to -2.5. But the pity on this is that most of them go undiagnosed and untreated. And so the osteoporosis is a significant cause of morbidity, mortality, and of course, it's a socioeconomic burden on the society and nation. It is estimated that by 2050, hip fractures worldwide are projected as 6 million per year. And as we know, this is a preventable disease, and the prevention starts early in the childhood or even in intrauterine life. So prevention is always cheaper and better than treatment. So prevention and treatment of osteoporosis reduces morbidity and mortality. So this shows how important this topic is for all of us. There are so many risk factors for primary osteoporosis, which include non-modifiable, modifiable, and environmental factors. I will not go into detail of it as you all know about it. And risk factors are also for osteoporosis related fractures. Here, I would like to stress upon the history of fracture as an adult. This one fracture is a cause of another impending fracture. So if we prevent this one fracture, then we can prevent another factor coming in. And in modifiable factors, the importance of calcium intake and high protein intake, because low calcium intake is known for the low BMD, and high protein of acid kind of protein, which is contained in all the non-veg food and some veg foods. They replace calcium from the bone. So this we should keep in mind. And of course, the importance of vitamin D, because we have free sunlight in India, but still we are having a serious vitamin D deficiency existing in our population. One more thing I would like to stress upon is vitamin K27 deficiency. We all know that after the age of 50, there is calcium paradox in the body, where the calcium is deposited in arteries and kidneys and is depleted from the bones. Now, vitamin K27 is very important in reversing this calcium paradox, and which will allow calcium to deposit in the bones from the and replace it from the arteries and kidneys. This is an exhaustive list of the various factors like general factors, lifestyle, nutrition, medical conditions which are causing osteoporosis, and some drugs also are causing osteoporosis. I will not go into detail of it. Risk of osteoporosis can be tackled by the risk assessment tools. And these tools estimate the risk of initial disease in apparently healthy asymptomatic individuals based upon assessment of multiple variables. All of the risk models have advantages and disadvantages, and no single risk model is appropriate for all patients. That we should keep in mind. And the 48 tools, as per the literature, 48 tools were identified and 20 were validated, but only 6 have been tested in population-based settings. 3 for risk assessment of osteoporosis and 3 for risk assessment of fracture. So 3 tools which are being used for risk assessment of osteoporosis are OSTA, ORAI, and SCORE. As each tool has its unique strengths and weaknesses, this we should keep in mind. OSTA is a osteoporosis self-assessment tool for Asian. It's a simple calculation-based tool, and it is we can get it by deducting age in years from weight in kg, dividing it by 0.2. Low score, less than 1 is low score, and -1 to -3 is moderate, and less than -3 is high score, and less than 2 cutoff younger postmenopausal women for we should suggest for BMD testing, and it is influenced by ethnicity. And the green zone suggests that no treatment is required. Medium zone suggests that prevent the disease, prevent the further occurring of the fracture, and high risk suggests that treatment is necessary and prevention is also necessary. Osteoporosis risk assessment instrument was used in Canadian women of more than 45 years. The exclusion criteria were osteoporosis or osteoporosis treatment. Sensitivity was very high, 93.3%, but specificity was as low as 46.4%. And the scores vary from 0 to 26. And bone densitometry should be done if the woman has a total score of more than 9. Simple calculated osteoporosis risk estimation was also available for the risk assessment, and cut point of 6 or above, DEXA scan was advised because it relates to the T-score below -2. So sensitivity was 98%, but specificity was still very low, 12.5%. And the positive predictive value was 69%. The negative predictive value was -75%. It is of limited value, but however, it is was introduced since it was a very simple tool. Now we discuss about the risk assessment tools for fractures, and these are three tools: GAR1, FRAX, and Q fracture. GAR1 was developed in Australia, and it uses 5 variables: age, sex, number of fracture after age of 50, number of folds in last year, and BMD. It is a moderate to good discrimination ability. WHO developed in UK a release FRAX in 2080. It is a computer-based algorithm that calculates individualized 10-year probability of hip and major osteoporotic fractures. Currently, it is 71 models are available worldwide in 66 countries. Previously, it was in 11 countries. Now it is covering more than 80% of the world population. It is available in 35 languages and 3 million visits annually on website. And FRAX for Indian population is also available now. Previously, we were using that of Singapore and Sri Lankan model. Sorry, I can't read my slide. Okay. FRAX is a simple tool was developed, but it has so many limitations, and these limitations are called as FRAX caveats. Risk factors are dichotomous involving yes or no response and can result in either over or underestimation of fracture risk. Certain variables were excluded, for example, folds, and it does not take into account dose-response relationships. The increased subsequent fracture risk after initial fracture is considered a constant over time in FRAX. It may only be used in untreated patients. Those who are having on medication, we cannot use FRAX. BMD input is limited to the femoral neck based on available population data. On a patient ascertainment of rheumatoid arthritis, poor definition of secondary osteoporosis, and it is internet access, but all physicians cannot access internet world over. So that is a limitation. Relationship between BMI and mortality. And there may be racial or ethnic differences that influence fracture risk not taken into account by FRAX, and variability in fracture rates. So far, up to 10 adjustments have been identified to improve the performance of the limitations of FRAX prediction tool. But still, it's a valuable tool if used appropriately. Just as FRAX has limitation, it has strength also. It may have great potential to assist the clinical decision making and ultimately in improving patient outcomes. It is a tool validated over 250,000 patient year follow-up. It's an additional tool for fracture prediction with and without BMD. It aids in decision making in cases of osteopenia also. It's a simple screen test using BMI instead of BMD, thus avoiding unnecessary investigations in case of osteopenia. An advantage of FRAX platform is that it's global and subject to modifications. FRAX has a future and will see improvements in future with BMD inclusion and addition of artificial intelligence. Q fracture is a calculator can be used to work out the risk of developing any osteoporotic fracture or hip fracture alone by answering some simple questions. It was developed in UK in 2016 and is intended for use in UK, England and Wales and Scotland. Fracture risk assessment should be carried out preferably using Q fracture prior to DEXA in patients with clinical risk factors for osteoporosis and in whom the anti-resorptive treatment is being considered. It is well calibrated with high discrimination and good predictive accuracy. Some other one or two other tools also are on the web. This is Canadian Association of Radiologists and Osteoporosis Canada. It was developed for the Canadian women. This is simple tool which suggests that if it is less than 10%, it is low risk. It is 10 to 20% moderate risk where the prevention strategies should be started, and high risk means active treatment should be started, which is more than 20%. The another tool is screening of older women for prevention of fracture. And this we can find in detail in the website of scoopstudy.ac.uk. In evaluating the risk factors for osteoporosis, a careful history taking is very important. And based on careful history taking, focused physical examination should be carried out. And according to the examination, necessary laboratory investigations to be done. And then patients should be sent for the BMD testing, DEXA scan, if needed. So these are the basic essential lab studies. I will not go into the detail. And if needed, more advanced lab investigations can also be done. DEXA scan is a gold standard for the diagnosis of osteoporosis and fracture risk. It's a fan beam X-ray bone densitometer, which uses two different energy levels produced by an energy tube to estimate bone mineral content and bone mineral density. And it uses a low level of X-rays. A limitation of DEXA is that soft tissue within bone pixels, which constitute approximately 40% of the total pixels, cannot be evaluated. But the DEXA is using a very low radiation. Full body DEXA is using a very low radiation, that is 0.003 MSV. This is known by all of us that the WHO criteria for osteoporosis, that normal is -1 standard deviation, osteopenia between -1 and -2.5, and osteoporosis is -2.5 standard deviation, below -2.5. T-score is a number of standard deviation above or below bone mineral density of age-matched controls, and Z-score is number of standard deviations above or below BMD of young normal mean. In postmenopausal women, we use T-score, and but Z-score is used in young children and premenopausal women, and in secondary osteoporosis cases. So DEXA should be done in all indicated patients. That means patients at risk of osteoporosis. The diagnosis is based on the central DEXA of the spine, total hip or neck femur, and If it cannot be done, then lower 1/3 of radius also can be measured. Caucasian female normative database is used as a reference for T-scores, and lowest BMD score obtained from all sites is used for diagnosis. All postmenopausal women should be screened for secondary osteoporosis if history or examinations of systemic disease or low Z-score on DEXA. In the absence of new risk factors, screening BMD should not be performed more frequently, but can be done every 2 years. In glucocorticoid-induced osteoporosis, it may be repeated after 1 year. Every DEXA facility should calculate its precision error, coefficient of variation percentage, and least specific change. This should be done for each site and every technician. Follow-up and monitor change in absolute BMD values in gram per centimeter square and percentage, and not T-score. A number of available DEXA scanners is limited in India with only 0.26 scanners for 1 million population. So, we need other modalities to be used for diagnosis of osteoporosis and the risk factors for osteoporosis. So here is the place of other modalities, because DEXA scan is not available except the big metros and the big cities, and the rural population is devoid of it. So conventional radiography, like we used to do it in the past, whenever there was a fracture or something, this is a non-invasive chip, but it is inconclusive in early osteoporosis. Radiogrammetry and radiographic absorptiometry, it is cheap, accessible, but inconclusive again in early osteoporosis. Quantitative ultrasound, it is cheap, portable, and free of ionizing radiation, but diagnostic ability is challenged and it does not meet the WHO criteria. Quantitative computed tomography, QCT, I'll come to this in a little while, next slide. And peripheral quantitative computed tomography, that is PQCT, measure bone morphology in radius and tibia. And it is a low radiation exposure, and MRI. So now advantages, and if you look at advantages and disadvantages of quantitative ultrasound, it accesses 3D microstructure of bone. It differentiates between trabecular and cortical bone, and it assesses volumetric bone density. But radiation exposure is high except PQCT. But let me tell you, okay, this exposure is just like a chest PA, not more than that. As it is highlighted, it is not like that. Because I have come across this when I was in the Sterling Hospital, and where DEXA was not done, but only QCT was done. But it has limited availability. In Rajkot, only one machine, and it is high cost, but not costlier than MRI. It costs 3,200 to 3,500. That is just like MRI, or even little lesser than MRI. So MRI is also one more modality to be considered, and it accesses again 3D structure of bone. It differentiates. It also differentiates between trabecular and cortical bone. There is no radiation exposure, and it can diagnose macro fractures also, and it is potentially useful in assessing drug therapy response, but it has limited availability and high cost. So to conclude, managing osteoporosis has progressed from concepts to T-scores and now to absolute fracture risk calculations. In view of the limitations of using T-scores in isolation, there has been a move towards assessment of individualized risk that incorporates multiple risk factors with or without bone density measurement to help predict future fracture risk. Thank you, friends.
Thank you, ma'am. Thank you so much for your wonderful talk. I would now like to invite Dr. Anita Shah, ma'am, to say a few comments on the talk. Dr. Anita Shah.
Yes. Thank you very much. First of all, Dr. Ami and Dr. Hina and the team of Rajkot Menopause Society, along with our great leader, Dr. Shobana.
Hi,
and
Anita,
Dr.
long time back from US. Nice to see you back.
Yeah. Sorry, in between last month I was not there and I missed everything. But I just was watching the messages that all is going so nicely that when Shobana is there, nothing is to be said. And
Anita was no less.
No. And I was so lucky that I have chaired this session by my beloved friend, Dr. Jyoti Ben. Dr. Jyoti Ben has covered the subjects in such a nice way that I think no words is I have to put. But then also, in nutshell, I would like to say that we all know that osteoporosis is a silent killer. And to prevent osteoporosis in the menopausal age, we should teach our and female to keep their bone mass good since when they are in adolescent age group. And that is the very important thing. And as a female in the middle-aged woman, we have to take care of all the females as a healthcare provider, that we should make them understand the risk factors for osteoporosis, and we should take care of them by doing various scores and various modalities which are available. And after this, there is a good panel discussion by Dr. Shobana, and I'm sure that she will also cover the everything, and she will make everything so easy that it can reach to the each and every listener. So I don't take much time.
No, I would like to say a few words here, Anita. You have not, Jyoti Ben also has not covered it. It's not covered in my panel either. The point is the clinical assessment of senior gynecologists sitting in a conference, whether they're osteoporotic or not. They're always in the front bench when they are presidents and somebody or the other. But whether you just see whether they're sitting like this, that means they've got osteoporosis. They have to stand against the selfie lene ke liye, when they're standing against the wall, just see if their head is touching the wall or not. And if that is not touching, that means they're osteoporotic. And take a photograph when they are 30 years, and they take a photograph of when they're 70 plus, and see if the height is decreased by 4 centimeters. So, and say hi to them and hold them around the waist and see if your 4 fingers are insinuating between the rib cage and, iliac crest. And if that is not there, then they are osteoporotic. So these simple things also have to be taught before we go into DEXA and things like that. Of course, DEXA will diagnose it much early, but people who do not diagnose it like that.
We'll have to add this in our screening test.
Yes.
Clinical testing.
Yeah, it is clinical examination. Yes.
Shobna's name, we will add it.
Not my name, so this is all there in the books. I just, as Jyoti Ben has got us all the recent advances.
You have come out with that.
That's okay. So I just wanted to add that.
Thank you, ma'am. Thank you so much. Let us begin with the second topic for the series today. So the topic is management in the osteoporosis. I would like to invite Dr. Shobana Mohandas, ma'am. Ma'am doesn't need any introduction, but still ma'am is a president of Indian Menopause Society of 2022-23. Ma'am is a consultant gynecologist.
It's okay. We'll shift over. You introduce the panelists because they are more important.
All the panelists of the session today. So panelist Dr. Hina Popat, ma'am. Ma'am is the secretary of Rajkot Menopause Society. Ma'am was also the past president of Rajkot Obstetrics and Gynec Society. Our second panelist for the session is Dr. Beena Trivedi, ma'am. Beena Trivedi, ma'am, is a senior consultant of obstetrics and gynecology practicing at Satnam Hospital at Rajkot. Third panelist of the session is Dr. Savita Tyagi, ma'am. Ma'am is the chairperson of the Rural Committee of Indian Menopause Society. Our fourth panelist, Dr. Shaili Modi. She is a senior consultant of Rajkot since 10 years working at a private hospital. She's also been the executive member of the Rajkot Obstetrics and Gynec Society. Then Dr. Ketan Thakkar sir. Sir is a senior most consulting orthopedic surgeon at Rajkot. Sir is also a recognized teacher at the Saurashtra University. I welcome you also, sir. And at last but not least, Dr. Devangi Vaishnav ma'am. Ma'am is a chief physiotherapist and a senior most consultant at GT Sheth Hospital since 31 years at Rajkot. I would invite all the panelists and we would like to start this session now. Dr. Shobna Mohandas ma'am, over to you.
Okay, thank you, doctor. We will now start with the panel, and 1 minute, I have not kept the share thing there. 1 minute.
You have to share.
Yes, so I bring you greetings from Thrissur, where I stay. That's my hospital there. And it's not going to slide. Okay. And the panelists have already been introduced. I will start with the youngest person in the panel, I think, no, Dr. Shaili. So can you simply tell us, Rajkot is good for food. All Gujus are good for food. What are the calcium-rich foods that the Gujus should be taking in Rajkot?
Yeah, ma'am. So basically, I agree that Rajkot is famous for products which are rich in calcium. I'll just enumerate a few. First of all, milk. So milk, again, buffalo and cow's milk.
Amul milk is there in Gujarat.
Yeah, ma'am. But we get both. In Amul also there is skimmed, gold milta hai, taza milta hai. Everything is written on the back of the packet that how much percentage of calcium and everything is there. But overall, in general, when I have to advise patient, I will tell them that if it's a buffalo milk, then how much you'll get, cow milk, how much you'll get. Another thing is till, seeds, which is like till. I tell them to eat a handful of till. That is sesame seeds, then cheese, then things like yogurt, which are easily made, curd and yogurt, which people can easily make at their home and are cheap and are readily accessible. Things like almonds. A handful of almonds will give approximately 6% of the daily values needed for the calcium intake. Then spinach, green leafy vegetables. So spinach and broccoli. Spinach and broccoli has high calcium, but I will have to tell them how to prepare it because they are also rich in phytates. Then yes, one more thing, nowadays young generation likes all those fortified drinks. So real ka aata hai and all, they are like all fortified with calcium. So sometimes
I didn't know that. I really didn't know that. I thought it's all junk and like not to be not to be allowed.
Yesterday only I gave my son real ka fruit juice and I read behind that and it is fortified. पहले नहीं आता था ऐसा. But now if you read it, तो उसके पीछे लिखा रहता है that some percentage of calcium and stuff. For that might be marketing gimmicks also. But yes, something is available. Then things like oranges, like 100 grams of orange will give me around 40 grams of calcium. So that's healthy thing. And broccoli and choda, like cereals like ragi. And ragi is not Gujarati.
Ragi is more in Maharashtra, no?
Yeah, but ragi. Then nowadays people do understand about ragi. So, but that would be only in some ethnicity groups. Things like choda, that is black-eyed peas, that is available in Gujarat and is frequently eaten. So that is what I would. These are the common things which I will tell them to eat. So basically, yeah.
In fact, whatever Shali has told is there on the net. There's supposed to be a calcium calculator on the net, but when you go to look at that calculator, it's containing all Western foods, not the Rajkot foods. So she has given us additional information, especially she's telling us to go to buy the fruit juice, go and buy real juice, not the other one, other products. No? So I hope the other companies don't listen to this talk on the net, but yes, but that's there. So now from that, we go to Dr. Devangi. We say that diet and exercise is important in osteoporosis. So nobody's got any pain and they're all sitting hatta khatta. There are many exercises. Some are good for cardiovascular, some are good for weight reduction, some are good for reducing cholesterol, some are good for osteoporosis. Which particular exercise, doctor, will you advise to prevent osteoporosis in particular?
Good evening, ma'am. There are a lot of literature available on the net, as you were rightly mentioned, ma'am. But what we put in one word is all the weight-bearing exercises and resisted exercises help in osteoporosis. And
Madam,
as
please specify what is a weight-bearing.
Yeah. I'm coming to that, ma'am. Weight-bearing exercises means there is a misconception regarding weight-bearing and resisted exercises. People take weight-bearing exercises as tying your weights and doing exercises, which are two different entities altogether. Weight-bearing exercise, under that comes walking, then something like cycling on the road, not the stationary cycle.
Because Dr. Devangi, that's practically impossible in Kerala. I don't know about Rajkot. There are no roads left where you can cycle.
We have tracks, ma'am. We have
tracks. Oh, you are like
tracks.
Netherlands.
Yes, ma'am.
Oh, so this is special webinar for Rajkot. Rest of India doesn't have cycling tracks.
And we have special BRTS tracks. We have special tracks on the race course also.
Okay, good. So cycling and walking. Cycling if you are in Rajkot, but in Kerala we don't have roads.
Okay, in that case, I would advise you to walk at a garden, because the floor on which you walk matters a lot, you know. There are many people who don't know that the floor on which you walk is very important. Like if you walk on a concrete floor, it puts a lot of brunt on your knees, which is a big no. Yeah, so you should be walking on a mud surface, ideally, as advised by the orthopedic surgeons. Even
my God, the Rajasthanis who are selling granite and marble will oppose you.
Yeah. But this is a lesser known fact, and lesser known fact, and at the same time less highlighted fact. And
so that you can't do now. That's unrealistic to ask people to have mud floors. What is the alternative for granite floorings and marble floorings?
We have gardens.
Okay.
Gardens, you can walk in gardens.
Particular wearing slippers
Footwear makes a lot of difference. The shock absorbing footwear of a good company, but everybody cannot afford Skechers. But
so people who can afford granite and marble in their house can also have
granite, concrete is the last on the list, ma'am. What is preferred is mud surface, which is there.
That's impossible. No, that's impossible.
So the best alternative for a common person would be to walk on garden.
Or wear good footwear inside the house.
Good footwear for the people who can afford it. And even with the good footwear, the floor does matter a lot.
You have given only one choice, Dr. Devangi, only walking and cycling in Rajkot. What else?
Yeah. Cycling, walking. And when it comes to physiotherapy, it is like, we all know that osteoporosis affects lumbar spine, hip and wrist. So best thing would be to concentrate more on the stretchability, flexibility, and strengthening exercises. And osteoporosis later on leads to imbalance. A patient has
which are the strengthening exercises?
Strengthening exercises of the low back include all the core muscle strengthening, which includes both the sides, the abdominals, the back extensors, even the lateral muscles, because most of the time the lateral muscles are overlooked. So that should not be the case. And both the anterior group of muscles, the posterior group of muscles, the back extensors, the abdominals, and the lateral group of muscles should be strengthened. That is one thing. Second thing is exercises to maintain the stretchability of the muscles, because as osteoporosis affects all these joints, there are more chances of lack of flexibility in the muscles because of the flexed attitude. So more concentration should be given on the extension attitude and extension strengthening exercises program. Then more of balancing exercises, because geriatric patients who have already developed, women who have already developed osteoporosis, they have problem with balance. So we have to strengthen the hip muscles as well, knee muscles as well, and flexibility of the calf muscles also play a pivotal role, because stiffness in the calf muscles can lead to frequent falls. So that is another bullet in the exercise program.
Okay.
So I think that would suffice.
Yeah. So good. So after 35, instead of looking at the mobile phones and answering hi messages, they should be looking at some exercise program besides walking or cycling in Rajkot.
Yes, ma'am.
Rest of the country, whoever has got cycling tracks can cycle.
Ma'am, so just a bit. Sorry, I'm interrupting you. But why? You must be knowing Dr. Anand Joshi, sir.
Yeah.
Huh? He does cycling in Mumbai.
Mumbai is there must be some place
So
where he's
I
going.
think if there is a will, there is a way.
I don't know. I mean, none of us want to die that fast.
No, jokes apart, jokes apart. But cycling
Mumbai,
anyway is
the difference between Mumbai and Kerala is Mumbai. I am from Mumbai. Anand Joshi was just 6 years senior to me in college, and he was in Mumbai. The traffic doesn't move at all. I say it moves at second gear. You can't go away from second gear. In Kerala, they do run, and you have scooters coming from left and right trying to overtake.
Right.
So all the cyclists, some 3-4 of them died. I think there is a cycling club in Trichy, and 4
so
of them
I
have
think
died.
everything. It is subjective in that case.
Yeah, but the point is exercise is important, and Dr. Devangi is really told us that we should keep away from mobile phones to exercise.
Yes, ma'am. Yes, ma'am.
Yeah. So now, hypothetical case to Dr. 1 minute. I forget whose name on the net. I'm not able to see. Yeah, Dr. Hina Popat. Dr. Hina, it's a 50-year-old lady, just recently menopausal, proper BMI. But the only thing is, father and sister had CHD at 55 and 58. So now she must be wondering when she will get her heart attack. She has got hot flashes and was prescribed HRT. And would you prefer to continue with that to prevent osteoporosis, or will you really shift from whatever has been prescribed?
No.
Good evening to everyone. HRT for prevention of osteoporosis is recommended by FDA also. Prevention and treatment for osteoporosis, HRT is needed. I will continue with, in this case, HRT and will give you the reason why. Estrogen doesn't appear to stimulate osteoblastic formation of newborn directly, but may have positive effect through insulin-like growth factor, transforming growth factor, and prostaglandin. Estrogen prevents bone mineral loss. It started within premenopausal period like this case, or within 6 to 1 year of physiological menopause, or within 2 months of surgical menopause. So even if HRT started after 3 to 6 years of menopause, there is a still response to estrogen therapy, and it increases the bone density, and this effect is maintained for 5-year period.
So definitely you should not get scared of CHD in the parents, because HRT is good.
Cardiovascular protection as well as osteoporosis.
Yes, that is it. So she will not get CHD. If you give her HRT, both her bone will be protected and she won't get GH.
So timely initiated estrogen can effectively prevent cartilage loss, and it should decrease the fracture radius, hip, and even vertebra. But only for the initiation of HRT as a sole purpose of prevention of fracture is not recommended in.
But she has got moderate symptoms, so it's worth it.
60, yeah.
Thank you. That's a very clear-cut message and a strong saying that if you have mild symptoms, you must take it, right?
Yeah.
No, but but life is very complicated. Don't try to find answers, because when you find answers, life changes the questions. So now we have a real complicated case, and I will ask Dr. Veena to take this. There was a 51-year-old woman. She was on desmopressin nasal spray, and this was taken because she had suffered PPH. She's 85 kilos. She's overweight, 5'2" height, and she cannot do without desmopressin. When she stops desmopressin, she gets polyuria. So she has to take that nasal spray, and so she continues to get exhausted. A minute, please, can you move out? I'm talking here. She continues to get exhausted on doing extra work, So she is amenorrheic after her last childbirth.
Yes, of course. Yeah. Madam says really in soup, because ISF-CIAN syndrome is very rare to see nowadays, because it is always after PPH and late. Patients get late treatment, very late, and then there is necrosis of that pituitary gland, and it leads to pan-hypopituitarism and all the consequences of it. So I think she must have been diagnosed as a Sheehan syndrome after one or more complications from long-term panhypopituitarism, like hypothyroidism, then adrenal insufficiency, hyponatremia, diabetes
No,
insipidus,
hyponatremia
even
was not
weakness.
there.
Okay,
But
so I think the weakness, the fatigue she has, it may be
but
because
she
of
has no
adrenal
history of hot
insufficiency.
flashes. She has
I know
no
she has no
history
history
of
of hot
flashes.
flashes. So
But she
that's
feels
what.
exhausted. So
because of adrenal insufficiency, she must be having fatigue because of adrenal insufficiency
but
in
does she
hypothyroidism.
merit estrogen either?
Yeah, so I am in favor of giving her hormones along with that steroid and other supportive treatment and that thyroid treatment to control her thyroid level. I would like to give her hormones
But she
because
even
since
without
long
hot
she,
flashes?
it's okay. It's not that only for hot flashes we give hormones. To prevent her burns also we can give her hormones.
Yeah,
In
she's got
fact, in her case,
osteoarthritis of the
I would
knee.
like
She has
osteopenic
diabetes
also. She has,
mellitus.
yeah, so she has everything. So we have to customize treatment in her case. So I am
Father has
also in favor to
undergone
give her
bypass
tibolon
surgery.
also.
That should not prevent her. That already Hina has told us.
That's true. But we by being cautious and have good follow-up, we can give her hormone. In fact, I am in favor to give her tibolon also because it is synthetic steroid and it has all the positive effect, estrogenic, progesterogenic, and androgenic effects. So her estrogen effect will prevent her
Anyway,
bone
Dr.
loss,
Bina,
and
this
progesterone
case
effect
was
will prevent. Yeah.
Yeah,
So
this case was
I'm in
presented
favor
at
to
a
give her HRT.
conference
Right.
with all the many other panelists, and we had opined that because she's only osteopenic, T
Yeah.
score is only minus 1.8 at the spine.
Right.
Only
Right.
calcium and diet.
But
would
since
be
long
enough.
she is deficit of hormones because of the Sheehan syndrome, since long she is
But
deficit of hormones, it
she's
is not that
deficit-
she has entered menopause, then only calcium level, then only estrogen level has gone down. Her hormonal levels are gone down since years
Hormonal
to
levels
decades
were
together.
normal, FSH levels were normal. Just because of Sheehan
That is
syndrome, she
before
was
10
having
years.
a
That is before 10 years. Her FSH level was
now
normal
it
before
may
10
be low.
years. But now
Anyway,
it may be
there
low.
is a difference of opinion, but this is a touch and go case where you can say you just give her calcium and diet, or maybe you can give
And then
her
lifestyle modification, everything else she has to do. Like she need to reduce weight and she has to take care of
reduction
her.
of weight with
Yeah, that is
desmopressin is a little difficult because
that is
desmopressin by
difficult.
itself
Yeah,
makes you
the
put on weight.
vasopressin itself lead to put on weight. Yes, yes.
Yeah,
And she
that
can't
is-
omit desmopressin. Otherwise, it became difficult. Her life became difficult.
Yeah,
So in
that
between, we
was-
can give her calcium and other phytoestrogens, soya isoflavones type of things, and then in between hormones for some time, may not be for longer period of time. So this is customized. So we have to keep her under strict follow, and then we should give her. But of course, I'm in favor to give her hormones, not only calcium, because
Okay,
she's such a
so
complicated
I'm just
case.
giving an opinion of another set of panelists. I will
Right.
take your opinion also, and
Right.
All the panelists and all the
Yeah, so we
audience
need
are
your expert
intelligent,
opinion also
so
for
they
that,
can
yes.
they can take their own
Definitely.
opinion on that,
Yeah.
right? So we will
Yeah.
leave it at that. Now this lady is 60 years old and she's off desmopressin, and she did not take hormone therapy anyway, and so she's okay now. She's continuing to have this thing. So bisphosphonates with antacids should we give?
She is not having too much osteoporosis because the T score is not that low.
So there is
I
no
don't think that we
indication.
should give
Only because
bisphosphonates,
she's
no
feeling
indication,
tired,
yeah.
you are saying it could be part of estrogen deficiency. not
And could be
just-
adrenal insufficiency because of panhypothyroidism, hypopituitarism. Yeah.
Okay, thank you, madam.
Thank you.
So now we always have these patients who say that I eat very little, I put on weight, you know. Suppose a 50-year-old postmenopausal woman with multiple complaints. She had come to me once. She said she's got backache, body ache, knee pain. She can't move much. I can't move. I can't move. Bilateral edema of feet, and she's feeling distressed and depressed. And then she had visited another gynecologist, and she said she doesn't eat much. So the gynecologist made fun of her, and she was so distressed. They said you exercise and you diet, but she can't walk because she's got pain. So she told her, I can't exercise. What do I do? Now, Dr. Savita Tyagi, please tell us what to do with this lady.
At the outset, I am thankful to Rajkot Society for making me part of this very interesting panel. And good evening, Shobna ma'am, and all senior persons here, and all the members whosoever attending this webinar. And as we all know, after this osteoarthritis is a case. She couldn't exercise because of edema and knee pain, and she was already on a. Remember, she came back to. If she is coming back to me, I will go for her to for her all investigation done, including her this thyroid, lipid profile, her ultrasound, her breast examination, and also because it is not possible.
Incidentally, her thyroid levels were really low. So
then if she is having hypothyroidism, I will put her on the altroxin tablet according to the requirement, whatever is the level of her TSH. And I will also advise her to take calcium along with the vitamin D3, the supplementation, because maybe she is not taking the proper diet, and also ask to do some exercise when whatever she can do in a bed, because so many exercises are there and she can do even if she is not able to walk for a long distance, because she's having knee pain already, which may be because of osteoarthritis. And I don't know why she was given Evandronate. What was her BMD?
No, she was having pain, no? So I gave her Evandronate and calcium, and all her pain reduced. She was so happy and she can walk. She was she couldn't even walk first time because
she is
first
only
edema because of thyroid, and then
yes, ma'am, we can start this Evandronate also, and also because she's only 55, so we can also give her the MST, because MST is also very much helpful at this stage of her life. And if she's having no other contraindication, as I see in this patient, so I can start her this HRT also. This HRT is very good, and we can give it up to the age of 60. If and we can in follow-up see whether if she's having any problem along.
So these are real life cases that can come to any one of you.
Yes, ma'am. Osteoarthritis is a very common problem at the age of 55. It is a degenerative disease, and as we all know, these estrogen receptors are present in not only in the bones, muscles, also in the joints. And so if the patient is given it, although it is not very much conclusive whether this hormone therapy is very much helpful for osteoarthritis or not, but so many studies has been done which show that when these patients are given these hormone therapy, definitely there was a less damage to the bones of these knee joints like patella, or less thinning of these bones, or even the whatever thinning was there, it was reverted back after taking the treatment.
So all the gynecologists who are running to the lift, they may need this sometimes. Don't have time for exercise, don't have time for dieting. So sometimes HRT has to be taken, I think. No?
Yes, madam.
So
and
that's what
I can continue this this treatment up to the 60 years, and if it outweighs the benefits are better than this, then when we can continue.
So that's a very clear-cut message. Either you give Evandronates like I did, or you give HRT like what Savita is saying. Now we'll move on to our orthopedic colleague, sir.
Good evening.
Good evening, sir. Dr. Ketan Thakur. Now she's one patient who had heart attack, and she had angioplasty. She's postmenopausal, and you have treated her for fracture. She's put in a plaster, bedridden for that much time, and DEXA is showing -2, sir. What will you do?
Okay. First of all, madam, one thing is very sure that even in spite of the fact that she has had a cardiac event, it does not put me off in using the bisphosphonates, because at her age, with the kind of scenario that she has right now, bisphosphonates would be the first choice to use in such cases. The question would be, what bisphosphonate should we use in such cases?
Now, to be honest, sir, will you give me an honest opinion? In all your fracture patients, do you always routinely give bisphosphonate? How many people?
We actually request them or suggest them, and in fact write a prescription also. The only problem
is your discharge card on a patient with a plaster always contain a bisphosphonate?
No, definitely not, because we have to counsel them, madam, because this is a long-term treatment, and once we start it, we need to make them understand that only if they continue this for a minimum time frame of 2 years, that's when they are going to get an advantage out of the bisphosphonate. Because until and unless we do a proper counseling and they are going to actually listen to it, because at times we just want to give them a trial for 4 weeks, and once they come back to us, we want to assess whether they are happily taking it or not. At times they don't.
Unless you have enough 15 minutes time to counsel your patient, you can't write it in the discharge card.
Absolutely, madam, because it has no point. unless until we have done a proper counseling, a lot of people fall out of it. And that is where we are going wrong. Because bisphosphonate,
so you should have time for counseling.
Definitely, because otherwise it has no value, no role whatsoever if we don't counsel them adequately.
Sir, can you please tell us, gynecologists, what are the briefly, how do you treat osteoporosis besides HRT that all our gynecologists have told us already? So,
frankly, we definitely tend to avoid the hormone replacement therapy because it's not our terrain. We do depend majorly on the bisphosphonates. Now, at least most of the orthopedicians, I can vouch for that, would depend either upon the oral bisphosphonate, which is alendronate, or risidronate, which are the two major choices as far as the oral preparations are concerned. Both of them can be taken on a weekly basis, both for prevention and treatment. The alendronate should be given in a dose of 35 milligram for prevention, but we are considering that most of the perimenopausal females are going to land up into osteoporosis.
So
and
why do you not give ibandronate?
Ibandronate, madam, very clearly it has been said that it is majorly helpful only in spine osteoporosis.
Only for spine.
Exactly. Peripheral osteoporosis in the hips and the wrists is not very well taken care by ibandronate. And that
but
is
the gynecologist, you always see patients with backache. So we are happy with ibandronate.
Perfect. I don't deny that,
but
madam.
As an ortho person, you won't depend on ibandronate.
I would not solely depend upon ibandronate because we do get a lot of patients. Actually, Colles is the first thing that we turn up with as far as the age chronology goes. Colles is seen first, then we come across the spine, and then we come across the hip fractures. That's how it proceeds.
For my patients with hysterectomy, suppose they complain of backache, I routinely give them ibandronate. So they won't blame hysterectomy for the back pain.
I entirely agree with that. Yeah. I would just suggest that we would ideally look into a DEXA scan and then, of course, prescribe it. But
Rajkot has got DEXA scan, tissue doesn't have.
I understand that matter, madam, altogether. But at the same time, giving ibandronate once she's postmenopausal, I think is fairly a game thing.
So for you risidronate, alendronate, if you have enough time for counseling.
And compliance, agreed. There are a lot of people who are not very happy taking once a week tablet. Then we go on to zolendronate, which is once a year injectable.
So just give one injection and you forget it. Khatam. Just like
Exactly.
our Mirena treatment. You put it in, it's gone for 5 years.
Like the old Honda ad.
Fill it, shut it, forget it.
Forget it, exactly.
Yeah. Okay, sir. This is the doses that sir told. Would you like to? You say that zoledronic acid. What is the cost, sir, per year? How much they have to spend?
To the doctor, it is available at the rate of 1,200, which is a very, very minimal cost according to me. 1,200 rupees a year is an absolutely acceptable.
It's quite cheap. I mean, come on.
If they go in the retail also, it will be available max at the rate of 3,000. But usually the doctors fetch it for the doctors and then they can give it to the patient at a much lower rate.
Okay. So anybody who has got a Colles fracture in this group, any relative, please take Dr. Ketan's advice. 3,000 rupees is worth it per year to prevent it, right? How long will you give it, sir?
Madam, it is definitely needed to be given for 3 years. You get a DEXA ideally repeated at the end of 2 years and then you watch for it. You really don't need to give it more than 4 years because people taking zolendronate or any of these bisphosphonates for a time frame of more than 4 years tend to develop the potential complications of jaw necrosis and an atypical fracture in the upper third of the femur. These are known to happen usually only after 4 years of taking it.
But if they're still osteoporotic, will you give a drug holiday for 1 year and repeat it?
Perfect, madam. That is how we actually do both for the oral as well as the injectable bisphosphonates. We give them a drug holiday for the oral ones. We give a drug holiday for 3 to 6 months, and for the injectable one, a definite gap of 1 year.
And after that, again for another 3 years, you can give.
That's done usually. Yes, madam.
Sir, do you really have patients whom you have followed up for 6 years and given this?
I remember.
You're the senior most person. I'm very sure you are the one person to whom patients will come back and again and again.
Alendronate and risidronate, I do certainly remember people taking it very regularly. I've got a couple of patients who have been on zolendronate who have taken a repeat shot of it after 3 years.
It's very rare for such things that patients will come back to you, the same doctor afterwards. They'll forget, they'll never come back to you.
On that aspect, madam, that's all problem that we are facing. All the same, nowadays, at least being that much senior, people do tend to come back.
Yeah, so that's a very good input that you have given us, sir, and you have encouraged us to use these injectables so much. Yeah, for this current patient, she was put on bisphosphonates for 9 months, and the DEXA values did come back to normal. So now we will move over from this valuable input from Dr. Ketan. Dr. Shaili, we come back to you. Everybody asks which calcium is good. So, and should you have encourage them MR who gives vitamin D along with that calcium?
Yeah, this is a very common question, and in market we are routinely bombarded with this. So still the old is gold. So calcium carbonate is highly preferred, because if if I'm to compare all basically calcium carbonate, calcium citrate malate, calcium lactate, calcium gluconate, and calcium phosphate. So these are the commonly available preparations. If on a point like quantity 1500 milligram, I take a baseline of 1500 milligram and decide that how much elemental calcium I need to have from this, then the highest which I'm getting it is from calcium carbonate, that is 600 milligram. So still my drug of choice would be to commonly prescribe calcium carbonate, because it is freely available, least expensive. But if I need it in doses more than 600 milligram per day, which is usually the case in postmenopausal osteoporosis, then I will divide it into 2 or 3 regularly and then give it. It has got GI side effects and complications, but if you give it with antacids and all, then it will be fine. Calcium citrate malate is more tolerable, but little more expensive for the routine rural population and all. So that I can avoid. The rest of it are not routinely much used. So yeah, calcium carbonate would be my drug of choice, and customize. If I try to do that, then second choice would be calcium citrate malate.
Okay, Dr. Shaili, that's a very good message, and you've given it reasons for your answers. Now we come back to our after diet and simple calcium. Dr. Devangi, everybody has got knee pain. So what exercises should we do for osteoarthritis knee, and what exercises we should avoid in osteoarthritis? If at all the knee pain is because of osteoarthritis, it could be rheumatoid arthritis, it could be osteoporosis, it could be anything else. But suppose it is diagnosed as osteoarthritis, what exercise should you tell them, and what should we avoid doing? Dr. Devangi? Is she there?
Ma'am, unmute yourself.
Yes, ma'am. Sorry. Yeah. Osteoarthritis knee is a very common condition that we come across in our OPD every day. Am I audible?
Yes, yes, you are audible.
Yes. So the best thing is we start off with, as long as there is pain, we all know that movements increase pain. So most of the patients who have a lot of pain, we start off with the isometric exercises. Isometric exercises is we contract the muscles, but there is no movement taking place. So that will help in taking care of the range of motion as well, and taking care of the pain factor as well. We all know quadriceps and hamstrings are the two major muscles at the knee joint, working on the knee joint. So we need to strengthen those muscles. We need to mobilize the knee joint, because later down, somewhere down the line, we all know that osteoarthritic patients develop flexion deformity knee. So it is one of our major goals to prevent those deformities like flexion deformity at the knee joint. Then deformities
can you please spell out the exercise that we should tell our patients?
Yes. Quadriceps drill is what we call that. Quadriceps drill consists of 4 exercises. First is static quadriceps, where we pull the kneecap. Hold it for a count of 5 seconds and then relax it. This
so
is
you
where
just extend your leg sitting in a chair?
Keep the leg extended. Press
in a
your
chair.
knee on a chair or on a couch, which is preferably on a higher level, on a dining chair level, because very low couch or very low sofa will also put a lot of strain on the knee joint. So it will be very uncomfortable for the patient to do exercises. So ideally, a dining table chair height is preferred, and the couch of that height is preferred. And static quadriceps
so
is the
extend
first.
your leg and count 10.
Extend your leg is the position. We contract the quadriceps muscle. That is, we pull the kneecap. We pull the kneecap, hold it till the count of 5, and then relax. That is isometric quadriceps. Then we all know the vastus medialis obliterans is equally a very important muscles for the knee joint and for the gait training. So that the function of that muscle is last degree.
So how do you make it function?
Yeah, so last 15 degrees of extension is done by the VMO. So we put a small pillow of this height, barely a fist height, that where only last 15 degrees of extension is possible at the knee joint.
Oh, like the pillows that Gujaratis have in the front room, no? Where you just sit like that.
Still thinner than that, ma'am. And we just see to it that the patient presses the knee and lifts the ankle. Lifts the leg from the ankle.
And once more, can you repeat it? I forgot.
Yes, you put a small pillow, hardly of 3 inches height, or even lesser than that. Put it under the knee joint. Ask the patient to press the knee and then lift the leg, lift the lower leg.
In sitting position?
Long sitting position. Patient sits with the leg fully extended. Long sitting position, the somewhat similar position to the Fowler position that you adopt. Okay, you getting my point, ma'am?
At least we can look it up in the net, so it's very nice.
No, I can show it if you
want.
want.
No, I get the idea now.
So you put a small pillow under
Dr.
the knee.
Shwetar, you got the idea? What she said?
I can demonstrate it if you want.
Yes, ma'am. You want demonstration?
If you're
I can do it if you want, ma'am, if time permits.
We'll make time for you, madam. This is so important.
Just a minute, ma'am.
Sure.
Is my leg visible?
Yes,
ma'am.
I'm putting fist underneath my knee. You can put a small pillow. I press my knee and lift my lower leg.
Okay.
Right?
Yeah.
This is what the vastus medialis obliterans does. And
I had forgotten the name of that muscle.
Vastus medialis obliterans. And
Okay.
this is very important because this will help in preventing further flexion deformity at the knee, right? Then we go in for static quadriceps in straight leg raising. The straight leg raising puts
lie on your back and you just lift
lie on your back with the non-affected leg bent. That is most important because if the non-affected leg is not bent, it will put a lot of strain on the abdomen and the lower spine. So the important criteria is to flex the non-affected leg when you are exercising the affected leg. If both the legs are affected, unilaterally you can flex the leg and do straight leg raising.
Don't flex both together. It's very important.
Yeah. But the thing is, you should, while doing knee exercises, you should not put brunt on your lower spine. That is the bottom line. So you do straight leg raising where the quadriceps are working statically and you're putting a stretch on the hamstring muscles because hamstrings, most of us have a hamstring tightness.
But you should not be heroic and try to lift both the legs.
Absolutely not. That's a big no because bilateral straight leg raising, 30 degrees bilateral straight leg raising is very, very high impact exercise for the lower back. So it is only for the fitness people, not for the people and women beyond 45. And the last exercise that we advise for osteoarthritis knee is sitting on a high chair with the knees hanging, the regular sitting position that we adopt, and extending your knee without leaning backwards so that you get pure movement at the knee joint. So these exercises are simple exercises, but they help a lot.
So when we go to the theater, you sit on a chair designed for male surgeons.
You can do exercises
and your
along
knees
with
will be hanging.
watching movie. Yes, ma'am. And the second part of the question is which movements are to be avoided. That is a very important thing, the ergonomic advice. So sitting on the floor. Sitting on the floor is a big no because when you get up from the floor, the entire body weight is being borne by the knee joint. So the knee is already worn out and you're putting more brunt on it. So you're avoiding that. You are avoiding cross-leg sitting. You have to avoid staircase climbing. This is again debatable between the orthopedic surgeons and the cardiologists, but we have to find a way out. So
what about the slope? You have the
slope
slopes.
Slope is again a very high impact activity. So it is, if at all, it is inevitable.
So always lift, only lift.
Only lift. And slope, if it is inevitable, always do treadmill or walking uphill with a kneecap on. That helps a lot. That helps a lot. And most importantly, avoid prolonged standing, because along with osteoarthritis knee, women have a tendency to develop varicose veins as well, which are all interrelated.
So पुराने जमाने में रेशन का शॉप में नहीं तो गेहूं पाउडर करने के लिए इतना लंबा लाइन में खड़ा रहते थे हम लोग. So maybe that's why we all got osteoarthritis.
So yeah, these all are the
in Kerala, in front of beverage shop, they have all such long queues, prolonged standing.
Yeah,
I hope that is not there in Rajkot.
No. So these are the simple things and simple exercises, but which help a lot.
Okay, so we'll go on to the next one. Thank you so much. It was a very useful answer, and I
Thank you,
wouldn't have
ma'am.
had
Thank
a
you, ma'am.
better person to give such a lucid answer for this. We are
Thank you,
really
ma'am.
enriched by you, ma'am. So now, Dr. Hina, you know you have rich grandmothers and they have a lot of money in their money. So don't they say this drug is cheap or costly. So they may or may not have renal failure. So would you advise preventive therapy for them? And they can't take bisphosphonates because they are bedridden. They have to sit up in bed now. So you can't take oral bisphosphonates. So give us an input on injectable osteoporosis prevention and other things. Dr. Thakkar has already given some advice, but some more can you give us, please, Dr. Hina? Dr. Hina? Dr. Hina? Please unmute yourself. I can't see you. Dr. Hina is there? Can you please call her up if anybody's got a phone?
Yes. I'll just try to call her, ma'am.
She's not there, then we will... because a slide is being shared, I can't see everybody's face. I can't see Dr. Hina here. She lost a connection. Okay, then we will ask Dr. Thakkar, Dr. Ketan to answer this question, or anybody else from the panel would like to answer this.
Yes,
What to do with the bedridden people?
Yes, ma'am. If the patient is bedridden, then we can advise her to go for the IV injections of this zoledronic acid, because she can't take oral medicine or oral bisphosphonates, because these or if she is geriatric, and also we have to advise her to supplement with the vitamin and this calcium. And if there is document, if patient is having some high risk for the fracture or this T score is more than -2.5, then teriparatites can be given to her for 20 milligrams subcutaneous daily for 1 to 2 years, or denosumab is also one option. That if patient's creatine clearance is more than 30 milligram per ml, then we can also switch on to the denosumab.
Denosumab is available in India. It's little costly,
yes,
but
madam.
It's available. And I think all our grandmothers, we should not just forget them. And if they, even when you have your own bank balance, you should remember there are certain drugs like denosumab and things like that available. Although it's costlier than the 1,200 or 3,000 rupees wala zoledronate that sir said. But if creatine clearance is less and they are on dialysis and things like that, you have to think about their bone also.
Yes, ma'am.
Right? And get denosumab from whichever part of the country it's available and give it to them. Our orthopedic surgeons, I'm very sure, will know how to give it, but we should insist that they give it to us, right?
Yes, ma'am.
So that's a clear-cut message that Savita has given us, and the public should be aware of this disease, and we should give adequate calcium and vitamin D. Dr. Beena is there?
Yes, I'm there.
Yeah.
Yes,
so
I'm
hot
there.
flashes in 45-year-old woman,
Yes.
how will you treat? Simple
Yes.
question.
Yeah, she has osteoporosis also, and if hot flush, then of course estrogen is the gold standard drug for her. So we should give her hormone therapy. And to her also, we can give her tibolone. It is also good result for hot flushes.
Okay, that's a
So we
good
should
thing.
give
You
her
can't
hormone.
forget the good old tibolone that only you give estrogen, because it will also help in everything. You don't have to substitute with progesterone either. In your practice, do you give a lot of tibolone or do you give a lot of estrogen? Because you don't have to give two drugs.
No, we give a lot of estrogen, not Tibolone, because sometimes it is not widely available in all medical store nearby, near to the patient, and it became costly affair also to some patient. So we
But
give other estrogen,
so
which
anyone with hot
not Tibolone,
flashes, instead of ibendronate, it's always better to give
Tibolone, yes.
yeah. So that is a clear-cut message. I'm so sorry that it was repeated, this thing. So, and what about the vis-a-vis?
Bisphosphonate?
Is HRT good or bisphosphonate good?
I think there is no clear-cut evidence to compare both. Both has its own pros and cons. So one is not superior to other. We can't say that. So I think orthopedics are using bisphosphonates and we are using estrogens.
Yeah. So there are no
because we are comfortable with hormones, our hormone, and they are comfortable with their bisphosphonates. So that's the only thing I can say. Otherwise, there's no clear-cut comparison.
But she's
in my
got hot
mind.
flashes, so maybe. But there are no head-to-head studies.
Yeah, there's head-to-head studies for that.
Orthopedics are good or right, or gynecologists are right. Right? We don't have.
There's
real
always
studies.
combination of both is better. Menopause is multidisciplinary approach. So we should have a combination of everyone.
Okay. So now we come back to Savita Tyagi for her own question. And they have, you cannot forget secondary causes of osteoporosis.
Yes, madam.
What are the medical conditions which you should look for in osteoporosis? I know
Maybe
we are not medical people, but still when they come to you, you have to know about all these things. Huh?
Yes, madam. Maybe endocrine factors like patient may be having hyperthyroidism or hyperprolactinemia, or maybe having hypogonadism, diabetes mellitus type 1, nutritional disorders, tumor secretions of parathyroid hormones related peptide Cushing syndrome, eating disorders, gastrointestinal disorders like patient is having liver disease, gastrectomy, intestinal bypass surgeries, malabsorption syndrome, patient is suffering from, or pancreatic diseases or celiac diseases are there. And also patient is having hemophilia, leukemia, lymphoma, sickle cell anemia. And if patient is suffering from these factors, these patients are more prone to develop.
So, and these are all real life patients these days. People are living so long that they do come back with all this. Now, organ transplantation is so common nowadays.
Yes, ma'am.
So
Nowadays
that
it
is
is very
what
common.
are the drugs, common drugs that can cause osteoporosis?
Yes, we have to know whether patient is taking any anticonvulsant therapy or on any glucocorticosteroids, because of the asthmatic patients are usually put on these steroids by some quacks also. Then some antidepressant drugs like fluoxetine, or patient is on a methotrexate or on
very commonly
patient is,
prescribed things.
Yes, madam. If patient is hypothyroidism and taking levothyroxine in a higher dose, then she may also having
very
symptoms
important.
like
Most people are taking L-troxine.
Yes, madam. So it is very important to follow these patients when we are giving the patient prescribing this levothyroxine. And
Okay, so
also patient is on
fluoxetine,
the
glucocorticoids,
Yes,
and
madam.
thyroxine are one of the
That is
the
very
real
important.
common
Both
drugs.
of these things are very important because we usually miss these two things. So, and patient is on heparin or higher dose of the vitamin A. So we have to know whether the patient is taking anything like that, then these patients are at high risk of developing osteoporosis, then we have to take them accordingly.
Okay. So now Dr. Ketan Thakkar,
Yes,
real
ma'am.
bad osteoporosis, lot of money and scared of the theater and everything. But patient is stooping, patient is on wheelchair, you need 3-4 home nurses to look after that person. If at all any of us reach that stage, should we come to you for surgery? And do you have anything to offer us? Will you do the surgery or should we go to specialized centers? If there are specialized centers, which part of India they are available? Who are the best people for it and who can do these things? You should know all this because you never know what stage of life me or you or even our relatives can enter this.
I entirely agree with this, madam. Nowadays, spine is becoming a very specialized region, and combining it with osteoporosis pathology, it is definitely sort of becoming a super specialization that we know of. Now, as far as the spine fractures are concerned, we know that we tend to get a compression fracture, a wedging, which may be painful to a few, which may not be painful in the long run if they do their back exercises very well on a regular basis and have a change in their lifestyle. So not all fractures which are compressed and wedged need a surgical intervention. That's the first important adage that we should know. The ideal indication for operating or doing a intervention in a case of vertebral fractures is if there is a non-union of the vertebral fracture, which we come to know only through an MRI. We need to do what is being shown in this slide, a kyphoplasty and or a vertebroplasty.
So is it done in your center, sir?
No, ma'am, it is not done in my center where I work, but there are a few centers in Rajkot which take up this. But once again, it is very, very limited because the indications
that means
ideally are very
has
few.
got people who is doing it.
We have a couple of spine fellows who do this in Rajkot. But once again, having had a reasonable discussion with them, they need to once again go into a lot of counseling.
So how many days admission it takes and how costly is it?
The admission is just 24 hours, madam, ideally speaking. And it is definitely not requiring any form of full-fledged anesthesia. It just requires a local anesthesia. And you can mobilize the patient in a couple of days' time. It's not necessary to remain in the bed.
And how costly is it, sir?
Madam, the cement that you inject inside, which is the necessary thing as far as the vertebroplasty goes, costs you somewhere around 20,000 rupees to the hospital. So usually they do charge a little bit more because this is done in corporate setups. But the cost actually on the paper, printed cost is 20,000 rupees.
Oh, that's not that much, sir.
Yes, but the procedure and the entire thing will ultimately work up to be somewhere, if I'm not mistaken, up to around 50,000 rupees, which again, I think considering the improvement in the lifestyle that they tend to get is definitely doable.
Yeah, that's the thing. I think you don't need a home nurse if you can walk about.
Another thing, madam, which I wanted to add up here is, as I told you, the indication for doing a plain vertebroplasty or a plain kyphoplasty is very limited nowadays, because in the younger generation,
उसमें तो ये आ रहा है म्यूट माय ऑडियो और ब्रैकेट में अल्टरनेट प्लस ए.
Somebody please mute their audio. ClearNet, please mute all other people.
तो भैया मेरा तुम्हारा वो तो है.
Yeah, Debolina, are you there? Please mute everyone.
Done, muted, done, ma'am. Yeah.
Okay, Dr. Thakkar.
Yeah. So the indication is very limited for doing a plain vertebroplasty or a kyphoplasty. Ideally, most of the spine surgeons, they prefer doing a fixation with the metallic implants as well in the relatively younger lot. This pure vertebroplasty would be indicated only in ladies who are above the age of 70 and are reasonably fragile.
So besides what is shown here, you also have metalloplasty. That's what you said?
Metallic fixation by screws and plates like they do in any trauma.
Okay. Oh.
So that is
so, but the bone will
done.
be so thin and osteoporotic, your screw will, I mean,
no, that is where, madam, I'm trying to tell you that this is actually indicated in the cases who are like between the age of 50 and 65. Beyond the age of 65 or 70, obviously, you are absolutely right in saying that the purchase of the screws will be minimal. And that is why we can't think of doing that and just do the vertebroplasty as it has been suggested on these pictures.
Okay, so that it's doable and it may be worth it in very, very rare cases.
Exactly. There are very selected ones who will really understand the value of this procedure.
Yeah. Okay, sir, anybody, either you or anybody, sir, what are the anabolic treatments for osteoporosis? Because there are representatives who give this and it's available and none of us are really knowing about it. So, sir, can you please tell us about this?
I would just like to highlight this one fact that anabolic would in today's world mean only the teriparatide. That is the synthetic parathyroid hormone, which is the only thing which can actually make new bone. Now that is, of course, being promoted and propagated in a big way nowadays because it is the new baby of the osteoporosis treatment. I'm telling it a new baby. It is in the market for more than 20 years now. The only thing is now people are becoming more aware of it because people are living longer and the need for this has been increasing over the time.
So how much does it cost and how long should you take it and how is it?
The Indian version from dependable companies is around a minimum of 3,500 rupees per month.
Okay, daily injection.
Daily injection, subcutaneous injection, and
like insulin.
Like insulin. That is how we tell people that it is like insulin. Only thing is insulin is lifelong. In most of the cases, this is like you need to give it for now. The time recommended is 2 years.
Only 2 years, they have to take 3,500 rupees per month.
Per month.
Do you have to definitely do a DEXA before you decide this, or how do you decide?
Ideally, yes, madam.
Okay, if
Not
suppose
only DEXA, but
if you don't have a DEXA?
I do agree that DEXA may not be available readily, but if they have been having fragility fractures in the past, I think it is a good indication beyond the age of 65 to put them on teriparatide, or maybe they have already
So all
taken
these gynecologists
bisphosphonates.
who are having their Colles fracture and things like that, and they're like that, besides putting a plaster, they should remember to take their parathormone injections.
I would suggest only after the age of 65, because I would still consider below 65 the
As
young
young.
old kind of people. I don't want them to be on teriparatide, rather they be on bisphosphonates.
Okay, you are the bisphosphonate person, sir.
The teriparatide I would just reserve for the severe cases. You did mention that suppose we don't have access to DEXA, but ideally we do need a DEXA score of below minus 0.3, minus 3 to start teriparatide. It's not a absolute indication, but it's a relative indication that below minus 2.5 you can still rely on bisphosphonates.
Okay, sir, that's very good. At least we should know that people who are bad on that, and you should know that such things exist at least.
Yes, madam.
And you have
Certainly,
given a
it is
very
definitely a very helpful tool nowadays for most of us, because we do get a lot of patients who have hip fractures, and it's difficult, as you told previously, to put them on oral bisphosphonates, and then this comes into picture.
Okay, sir. So now Dr. Hina had gone out and she's come back. I will ask her the last question of the day. A woman on steroid inhalers, that's my mother's sister. She's just as tall as the 12-year-old person sitting there. And for steroid inhalers, what you can obviously know that she is osteoporotic because her height is so low compared to the 12-year-old, and she's shorter than my mother sitting there. So what should be the option to treat glucocorticoid-induced osteoporosis? Dr. Hina? She's again gone back?
Yes. No, I am here, ma'am.
Okay, Dr. Hina.
Yes. Ideally, we should just prevent the fall prevention measure to her, and if she really wants, we can give denosumab.
Why denosumab straight away? It's costlier than zoledronic acid or parathormone. Why have you straight away gone to denosumab, Hina?
So it is a human monoclonal antibody, and for treatment of osteoporosis is recommended by FDA. It has very less side effect.
It has less side effects. Dr. Thakkar, would you agree with her that on all patients on glucothyroid corticosteroid therapy, we should directly jump onto denosumab?
I would not necessarily agree to that, madam, because I do believe still, as I had told you previously, that bisphosphonates and teriparatide would actually form the major form of treatment in any of the cases to begin with. And once they have done with the entire regimen, then you go to denosumab is the rule of thumb in most of the cases.
Yeah, in my auntie, they were giving her teriparatide, and she wouldn't even talk earlier. But when the pain went off with teriparatide 6 months treatment, she started talking and smiling because the pain was not there. We never realized she was having so much of pain. So they don't talk to us. You don't realize that they are in pain. So either bisphosphonates or teriparatide, or if they have got renal failure, well, like Dr. Hina said, they can go on to denosumab. So, but keep your old ladies pain-free when they're 80 plus, 90 plus even. Even 90 plus, don't write them off. They may live till 100. These days, you can't say. So we should learn. Yes, sir?
Yes, madam. A small point when you mentioned about the pain element. One thing which has been sort of conveniently overlooked at most of the times is the pain element in such ladies, where the calcitonin nasal spray, it has been sort of over-marketed in the past. But I would say that if the pain is the concern, giving calcitonin spray helps a lot for 3 to 4 months. That's when it should stop.
So old is gold.
Calcitonin, but people have been overusing it like as if it's been a wonder drug or a magic drug. That's actually not the case. It actually does not play a major role in the long run, but 3 to 4 months for pain relief, it's a wonderful drug.
Okay, so calcitonin along with bisphosphonates or teriparatide
should be the best.
Simple. So simple question in the end. So what are the fall prevention methods for elderly people? If somebody is there old in the house, so anybody can answer this. Maybe our physiotherapist can answer this. Are you there,
Yes,
doctor?
yes, ma'am. Yes, ma'am. That is what I had mentioned. Stretching exercises, especially of the calf
No,
muscles.
fall prevention. How should you
That
design
is
your
what.
house in such a way?
Yeah. Fall prevention, because osteoporosis, stiff calf muscles can lead to frequent falls. Muscle imbalance leads to frequent falls. Lack of flexibility in the muscles leads to frequent falls. So what we can do is we can concentrate more on the balancing exercises, stretching
So what about
exercises.
the designing of the bathroom, designing of the rooms?
Designing of the
Should
bathroom,
we have
that
railings
is
in the
more
side of the
important.
bathroom?
There should be a railing in the bathroom, so that a geriatric person has a aid in getting up from the commode. Same way, when in our apartment type houses where there are 2 steps, you need to put a railing. Even at the ramp for hospital, the railing on both the sides should be given, so that it becomes easier for the patient to hold on to the ramp and climb and descend the ramp. So all these are all this can
What
help in
about the
preventing
flooring?
fall.
Should we change the flooring?
Flooring, yes, very fine, and the mosaic flooring should be avoided, because most of the times people don't realize that it is there is a water being spilled there, and they land up falling there. Even in the bathrooms, people don't realize there's some water and they land up falling. So all these
Yes.
are activities of daily living.
Dr.
And
Ketan wanted to supplement something, sir.
Yes, madam. A couple of things. Always have the white lights everywhere, and the switch of the white light has to be next to the lady who's sleeping there and wants to go to the loo. That's the time when they actually fall down most of the times. That they
So I
need to
didn't
have
understand. So white light means what, sir?
nowadays a lot of these interior decorators, they tend to use the yellowish kind of light, the bulbs and all those things. So it is better to depend upon those traditional tube lights or the LEDs which are white in color, because that gives you a better lighting at night when they want to get up and go to the loo. Those are the times when they tend to have a fall. Another thing is they should have the switch of the light next to their bed, so that when they get up in the passage and everywhere, they need to switch on that light and then go to the loo. Number 2 is they should also be avoiding rugs and carpets everywhere. Because
they can slip.
Exactly, that is where. And you were mentioning regarding the design of the bathroom, they should avoid steps wherever possible, because in India it so happens that most of the places there is a small step going into the bathroom. Those are the places that they don't realize at night or in the early morning they are going to the loo, and then they miss that step and have a fall.
And then they come to you.
Exactly.
Okay. So I think I exhausted this thing, and we have reached 8:50. So in conclusion, women and their caregivers today are aware that lack of hormones can give a lot of problems. Osteoporosis and osteoarthritis are common accompaniments of menopause. Prevention of osteoporosis by way of exercise can be prevented by the presence of osteoarthritis, which makes movements painful. So first treat osteoarthritis and then you can do exercise. And in conclusion, also patients come with multiple problems. And so you give HRT solve some of the problems, and it should also reach out to the treatment of osteoporosis. And lifestyle modification should be stressed as much as drugs, and all the avoiding lifting heavy weights, walking, all these things should be counseled. And listening to me, the patient, is also very important. So with that, I came to the end of my panel. Thank you so much. All the panelists were so good that we have given clear-cut messages, I think. So. Over to the organizers.
Thank you, ma'am. Thank you so much for the wonderful discussion you did. Now, I would like to invite Dr. Jyoti ma'am to give her extra comments on the session. Jyoti ma'am is there?
Yeah.
Yes, ma'am.
Congratulations, Dr. Shobna. You are really great.
Yeah.
With
Thank
all
you,
the
Anju, for being there throughout.
Dr. Shobna is known for a tough moderator, but I think all my Rajkot colleagues have given you a tough fight, no? Right?
No fight. They were so good. My God.
Yes.
They're real
Yes. Absolutely. I mean, exclusively enjoyed the whole panel.
Madam, I am not from Rajkot.
I know, but right now you are part of us. Right now you are part of us. Okay. So, but absolutely, it was really, and Dr. Ketan Thakkar mentioned calcitonin, which I was feeling that it is missing, and he mentioned it. It's a very good pain relieving spray, which was available and which was used very commonly in past, but now also we can suggest in some patients. And moreover, raloxifene is not available somehow other nowadays. It was a good drug. I have tried it in so many patients in the past, but right now it is not available. And moreover, one more thing, Tibolone from Serum Institute of India, named as Cibolone, is freely available. And, in certain cases, we might prefer it than MHT also. So with this, congratulations to the Dr. Shobna and all my friends from Rajkot for excellent webinar. We really are going with the clear-cut messages, and it really will help us in our practice. Thank you very much.
Thank you, Rajkot. You have taken really lot of trouble in giving us very good faculties and arranging the whole thing. Anybody from the audience wants to say anything, they are welcome to interact. There is nobody.
You have covered everything so nicely, Shobna, so nothing is left behind.
Okay.
Nothing,
Shobna,
madam, except for congratulating you.
And let me tell you, Shobna, all the cases were jara hatke. All the cases
Very
were
practical,
hatke
very practical.
all practical and really needed,
Thank you, all of you. Thank you, all of you, for being there.
Madam, have knowledge of every field, so deep knowledge of every, whatever is given to you, madam, you cover everything so nicely. I don't know how much knowledge you are having.
Madam is caring elderly patients at home, so she is very, very passionately researching on those things which are affecting the elderly. That's why I think madam has kept her baseline for management
70 plus.
of 70 plus. Yes,
Yeah.
yes, madam. Really, I can understand why you are so passionate about this.
I know, because we are
So
exploring.
I am 72, so I got lots of tips.
Yeah, she herself. And you are sitting there and talking. So you are all inspiring.
Presentation by Jyotiben to remain fit and fine at 72.
And our founder president is 86 and she is so fit.
Yes.
So all these people are you, but all our patients are not that fit, no? So we have to help them.
Yes, right. Okay. Then. Good night.
Okay,
And
bye.
goodbye.
Thank you.
Good night. Bye. Thank you.
Thank you. Bye.
Bye. See you next week with Vijayawada. Bye.
Okay.
I'm Dr. Lalita. I'm Dr. Lalita from Madurai.
Okay, Dr. Lalita, tell me. Yeah, we can hear you, madam.
Very good. It was very good webinar, madam.
Thank you, ma'am, for joining from Madurai.
As well as the panel was also good. You asked very nice questions. It is all very important. And nowadays it's very difficult to look after the elderly people. So you have told us so many nice points, and thank you very much, madam.
I only asked, madam, the panelists were giving the answers.
Asking questions is also very important, no?
Yeah.
Asking questions is also very important. You know the answer. That's why you are asking the question.
No, not many. Some of the answers I really did not know. I learned a lot from the panelists today. I learned from all the panels wherever I conduct them. I learned something from everybody.
Yes, it was
Today
a
I
very
learned
good
a lot.
lecture, madam. A very good webinar. Thank you.
Thank you for all your
Bye-bye.
Madam,
Yeah.
Madam, I am Dr. Savitri from Madurai, madam.
Okay.
I've been listening to your webinar so many times. Very interesting and very useful.
Thank you, ma'am.
And
thank you.
Menopause webinars should be given equal importance like antenatal classes, madam.
Yeah, we'll reach that level in the end of my tenure.
Yes, madam. Because we
we'll try. Okay, ma'am. Thank you.
Thank you, madam. Thank you.
All so much. On behalf of the Rajkot Menopause Society, I would like to express my gratitude to all the esteemed delegates of the webinar for their presence and contribution to make this webinar a great Yes, thank you so much. I would like to extend my gratitude to our honorable guest of honor, Dr. Atul Munshi sir and Dr. Anju Soni ma'am, to take out the valuable time from the busier schedule and to grace the event. Thank you, sir, and thank you, ma'am, so much. I would also like to thank our president of Rajkot Menopause Society, Dr. Ami Mehta, to be a part of this knowledgeable webinar and share her knowledge as well. I'm extremely thankful to Dr. Jyoti ma'am and also Dr. Shobna Mohandas ma'am, who were the speaker for the session, to convey their knowledge and their deep thoughts on this wonderful topic. Thank you, ma'am. It was a wonderful session, and in a very easy language, you make us understand everything. Thank you so much. Further, I would also like to thank our chairpersons, Dr. Anita Shah ma'am and Dr. Varun ma'am, for giving their presence for our today's session and spend their valuable time with us. I would like to extend all my heartful gratitude. Thank you so much to all the panelists over there, Dr. Hina Popat, Dr. Savita Tyagi ma'am, Dr. Shaili Modi ma'am, Dr. Ketan Thakkar sir, and Dr. Devangi Vaishnav to share their knowledge with us on this platform. Thank you so much and have a good night. Thank you, ma'am.
And thank you, Debolina and ClearNet, for coming to IMS week after week and helping us with spreading knowledge. Without ClearNet, this would not be possible. They don't ask for anything
you
in
so
back
much.
return.
Thank you, ma'am. Thank you so much. And good night all. We are closing here for today.
Thank you.
Thank you, everyone. Good night.